So this is the lumps and bumps talk. Cardiac masses known and unknown. It's not a tour de force of all the exotica and things that we don't really see. I'm going to talk about commonly encountered masses. I'm going to talk about the simple rules for describing masses and how to characterize them. And in particular, I'm going to talk about myxoma and thrombus, which are the masses we commonly see and which require us often to come up with decisions, not only in the theatre, but also in the cath lab, increasingly, and in the intensive care unit. So the common primary cardiac tumours are by far and away myxoma, and these are the ones which we'll all have seen in theatres. The other cases very rarely require any kind of surgical intervention, and certainly malignant masses we won't see in the theatre. So before we look at some pictures, let's just think about the rules. First of all, if you think you see a mass, and commonly you'll see masses in the fluid film chambers, particularly, because this is where you get artifacts. So first of all, you need to exclude an artifact, particularly around the left atrium and in the right atrium. And the ways to exclude artifact are to take a different plane, move the probe around, and also change the machine settings, the gain and the time gain control particularly. Turn them down to try and exclude the artifacts. You also need to consider normal variants, and there's a sort of an exhaustive list of the normal variants we see. Most of them seem to happen in the right atrium, and I refer you to a text really to look at all these. But also, a very important principle is to look at previous studies. If you see something post-bypass that you don't think you saw pre-bypass, go and have a look at the studies. If you're seeing something that wasn't really described in the pre-op study, transthoracic or otherwise, go and dig the study out, get the medcon, have a look at the study that was done preoperatively, assuming there is one. So how do we describe masses? So, first of all, size, shape, what's the texture and location of this mass? Describe its echo density. Is it dense or is it light? Is it regular? Importantly, describe its attachment and describe its mobility, relationship to other structures, and also color flow within the mass. This won't necessarily always be communication with a cardiac chamber, but it may be. But also, for example, in the case of tumors, you can actually get blood flow and blood vessels within the tumor. So I'm going to talk about myxomas first of all. Most common intracardiac primary tumor, as we said before. Most common in the left atrium, also occur in the right atrium. 5% of cases are multiple. I've never seen one of these. I'm not sure if anyone else would admit to seeing one. They do recur. They normally have a septal attachment and are commonly treated surgically. They can be associated with problems beforehand, such as pulmonary hypertension to a large occluding mass. And they can be associated with problems afterwards, iatrogenic septal defect, and deformation and damage to our valves, and I'll show you some examples of these. So there's the left atrium, nothing much in evidence, so I think if we turn the probe round a bit, like we're used to doing, and pull the probe out a little bit, there we can see it, a rather horrible looking beast. And myxomas always do look rather sinister and nasty, although thankfully benign. So again, that's the same tumour. You can see the septal attachment. They're often seen in sort of slight variations of our traditional views. So this you can see we're around 0 degrees, and it's not a short axis, the aortic valve, but these are sometimes the best planes in which to look at the intraatrial septum. And what you would normally do is sweep round between 0 and 180 degrees, like the cardiologists do, to get a good view of the septum. Here's another example, slightly different gain settings. And you can see this one is very firmly attached around the septum. You can see the sort of variable echo density and the what look like cavities within it. You can see it's actually deforming the intra-atrial septum with the weight, pushing it into the right atrium. And you can see it's not really a very mobile mass. So there's quite a big septal attachment there, it seems. There's another view of it. You can sort of see the characteristics of it again and the septal attachment. There's the specimen the surgeon's resected, and you can see on the left of the picture, that's the actual piece of septum that the myxoma is attached to. This, of course, causes a considerable iatrogenic septal defect. So you can see there in the picture, the surgeon has put a pericardial patch over the intra-atrial septum, and we'll use our colour to determine whether that's been a successful septal repair. If in doubt, one could also potentially use contrast, but that's really more for cardiologists trying to find reasons to put devices in. Again, here's another left atrial myxoma. You can see this looks slightly different to the others, and you could confuse this actually with a mobile thrombus because it has that kind of slightly more dense appearance and is more mobile. Again, when you're investigating myxomas, always turn to the septum, pull the probe up and look at the septum in detail because it will usually be attached around the septum. And this, I can't show you this, but this had a smaller septal attachment and was much more mobile. When these tumours grow, they almost inevitably start to interact with the mitral valve and cause inflow problems, which is usually when people start to get symptoms, either that or occlusion of the pulmonary veins. I mean, as you know, these can grow for years and years without people noticing. I'm going to show you an interesting case of a right atrial myxoma, which led to certain complications. So there you can see the myxoma is attached, a very large one in the right atrium, a smaller septal attachment, and it's quite mobile. You can see the tricuspid annulus plane. This is a 0-degree plane again, showing sort of the aortic root, really. And you can see the tricuspid annulus plane, and the mass is prolapsing through the tricuspid valve, and it's sort of tugging that intra-atrial septum down. It's got the characteristic sort of variable echo density of the myxoma. And again, this is a sort of rotated view from an aortic valve short axis, really to focus on the septal attachment to the myxoma. And really that's what we're trying to home in on, to find out how big that attachment is. You can see there is some flow around the myxoma, around the attachment. So it's quite a small attachment. This is like an inflow-outflow view, and you can see how abnormal the right ventricular function is. There's a small bit of pericardial fluid there. So this myxoma has considerable impact upon this patient. I mean, I believe I recall their CVP was about 25, I think. So they put up with it for a long time. Here's a 4-chamber view, more traditional view that we would take, and you can see there the enormous myxoma interacting with the tricuspid valve, causing a significant inflow obstruction and impairing right ventricular function. And indeed, I can show you the colour, and you kind of wonder how this patient mounted any kind of cardiac output, where looking at that tricuspid inflow. So here's the next in the sequence. No, the patient didn't arrest. That was actually on bypass. But you wonder, looking at the size of it, how they didn't have an arrest. And there you can see a photograph. When our surgeons complain about us using phones in theatre, then they always ask us to take pictures of the pathology, so that's our excuse. The appearance of the myxoma is very much like it is on the echo images as well. You can see the irregularity and the sort of large nodular shape of it. So that's sitting in the right atrium. You can see the surgeons put a SVC and IVC cannula in so he can open the right atrium and really get at this thing. Okay, so post-bypass, what I've done is I've zoomed in on the tricuspid valve here, and we can see the anterior leaflet but the septal leaflet's not so much in evidence there. So let's put some colour on. And there you can see a very large regurgitant orifice. And you can see that pretty much matches to where the septal leaflet should coapt with the anterior leaflet. So the septal leaflet has actually been pushed down and is sort of basically stuck on the right ventricular septum. So we have a problem here. And again, taking a slightly different view, rotating the plane round towards a mitral valve, a right ventricular inflow-outflow view, you can see, again, we can replicate the size of that regurgitant orifice. So clearly the surgeon had to do something, and you can see rather than a de Vega suture, he put a tricuspid annuloplasty ring in here to reduce the size. And he did a very clever septal leaflet extension with some pericardium. And we have a look at the colour on there, and we can see that he's actually got a very good result from that. I was very impressed. And again, now you can just compare the before and after pictures. Okay. So with myxoma, it's very important, first of all, to look at the septum to see where the septal attachments are, and look afterwards at the intra-atrial septum when it's been removed for evidence of any communication. And also it's very important after bypass, particularly with these large myxomas that interact with the valves, to have a look at the valvular function. I'm going to move on to talking about left atrial thrombus now. The left atrial appendage is the most common site for left atrial thrombus. We see quite a bit of these, and we have to think about them quite a lot, particularly in regard to atrial fibrillation, mitral stenosis, and left ventricular failure, all of which are the conditions which predispose to left atrial thrombus formation. Unlike transthoracic, the sensitivity of TOE for left atrial appendage thrombus is 95 to 100%, similar to what which we find in aortic dissection. And we can often track spontaneous echo contrast, which points to the existence of left atrial appendage thrombus. So why is it relevant to us? First of all, intraoperative, and left atrial appendage amputation is making a bit of a comeback. Certainly, one of our surgeons amputates every left atrial appendage in patients who are going to be on warfarin, which I think is a very good idea if they have to interrupt their warfarin. We're doing a lot more cath lab procedures for ablation, patients stopping warfarin, a lot of TOEs being done to look at appendage thrombus and other complications that they may have in the cath lab. So we're getting involved in that a lot more. In the intensive care unit, cardioversion in post-operative patients who are in AF, which is, as we know, is quite a common complication following cardiac surgery. And also patients who've had a cerebral injury when we try and wake them up, and we don't quite know what the cause of this is. And also we get asked to anaesthetize patients for elective interval cardioversion. So we need to think about left atrial appendage thrombus. I mean, I think if we put someone to sleep for a cardioversion procedure and they were to have a stroke, I think we will be implicated in the cause of that and any case that may arise from putting that patient to sleep if they had an embolus. This is an interesting case. He was a patient who had a mitral valve stenosis, came for a mitral valve repair. You can see there's a slightly different echo density, but in the left atrium, just above the aortic valve, you can see the outline of the appendage, and you can see that's completely filled by thrombus, and you can see that thrombus is actually extending into the left atrium. This was a patient who had only stopped their warfarin for 6 days, and they'd managed to build this thrombus up. Particularly the combination of mitral stenosis and slow AF seems to be pretty significant. Again, that's the more usual 90-degree plane view where you pull back the probe and look at the left atrial appendage. And I think maybe you can even see a bit of Jorg circumflex, which I'm going to start to look for a lot more now, I think. And you can see there the shape of the thrombus in the left atrial appendage and the extension. That was the size of the thrombus that the surgeon removed. obviously, I hope we would all look at the left atrial appendage in any kind of cardiac surgery, but my exhortation would be, when you do a TOE, always document the left atrial appendage, record a loop, and make sure you document whether there was any thrombus there. You can see that's actually thrombus within the left atrial appendage. I don't know how clear that is. You see that the opening of the left atrial appendage with some thrombus towards the tip. It's another interesting case. This was very early on in my career as a consultant. And you can see that because this is actually a transposed video loop into digital. And it was a gentleman, an elderly gentleman. There was no particular indication for TOE. I was really the only one who was doing TOEs at this point. And people thought I was trying to make extra money, or I don't know. They were quite suspicious of me. But I found this a very compelling case for doing intraoperative TOE. So this is an elderly gentleman having a CABG. You can see the size of his left atrium, approaching 10 centimeters. You can see the poor longitudinal function and the poor overall left ventricular function. We're slightly off plane, so we can't see the mitral clearly. You can see the spontaneous echo contrast. And also you can see the thrombus within the left atrial appendage, and you can see it kind of fibrillating at roughly the same rate the left atrium will be fibrillating. And you can see that sort of slightly different echo density from the surrounding cardiac tissue. I identified this to the surgeon, and again, this was someone who was an AF who hadn't been on warfarin, but just treated with aspirin, which is probably what people did, the GP did 10 years ago. The surgeon stapled across the left atrial appendage. Following bypass, we had a look, and you can see what's happened. You staple across the left atrial appendage, and there's a very significant risk of the thrombus extruding into the left atrium, and actually becoming mobile. And so we identified this. We had to go back on bypass, clamp, and remove that thrombus. And this was a very powerful illustration to me as a sort of budding intraoperative echocardiographer of the value. And I think we can all see how much the expense of not picking this up would be. And that would buy me 6 3D probes, 2 machines, and probably dinner for 2 at the best restaurant in Manchester, the entire cost of the NHS of treating that gentleman. So just talk a little bit about cardioversion. It's beyond the scope of this talk. It's slightly disappointing that the cardiologists don't strongly recommend TOE, and even in the European Society of Cardiologists guidelines in 2010, there's a really rather tepid statement about TOE may be used for cardioversion. I think maybe as avid users, we would say something probably a lot stronger than that. I mean, my rules of thumb for cardioversion would be really to consider a TOE cardioversion for all patients in AF more than 24 hours. We have TOE readily available in theatres and intensive care. We're all very practiced in using sedation to do TOE. It's really not a problem and can save all the hassle of warfarinization, heparinization in patients who maybe have the risk of bleeding post-op. And I would encourage you to consider it for all patients in AF more than 24 hours, certainly more than 48 hours, which is in the international guidelines. And this includes pharmacological cardioversion as well as electrical. Right, I'm going to kind of wind up, and this is the final quick fire round, as they seem to have on quiz shows, and maybe I can ask your help in looking at some of these. So this was a case, is an aortic valve replacement actually, and post-operatively, I looked at the left atrial appendage, and this is what I saw. Can you see that? I haven't got a pointer, but if you see the left atrial appendage is here, and you can just appreciate there's a sort of small mass shape within the left atrial appendage. So I went and reviewed my preoperative study, and I'd saved a loop of the left atrial appendage showing me that it was actually thrombus-free. So I thought a little bit about this. the surgeon actually put a lot of tissue glue around the root of the aorta. And what we have here is an inverted left atrial appendage. I mean, we reported this to one of the journals. It's not very common, but it's sort of like the appendage, as you can appreciate, is a bit like a windsock, and it can invert quite easily. The decision for this was clearly to leave it. But we had to scratch our heads for a few minutes, but we decided to leave this alone. We gave some more filling, the left atrial pressure increased, and the left atrial appendage reverted to normal. And I don't know if I can just, I got the pointer on screen, so that's a normal left atrial appendage there. It may not come out so well at the front. A normal left atrial appendage there. And there you can see this kind of windsock inverted left atrial appendage here. So if you see something like this, always think about an inverted left atrial appendage. Again, this is one from early in my career which really took me by surprise, and it's actually it's a freeze frame, and it's transposed from analog video. But you can see here, when we came off bypass, this is a patient who had a mitral valve repair for stenosis, who had a very big left atrium, again, and you can see the left atrial appendage has actually been removed by the surgeon, but I can see this mass here, and I'm not sure what this is. I don't know if it's a thrombus. So again, I scratched my head a little bit, being still relatively new to echocardiography in theatre. But this is a gentleman who had a 9 by 9 centimetre left atrial appendage. In the previous picture, the left, not appendage, atrium. In the previous picture, the left atrium was only 5 centimetres. So where's the rest of that left atrium gone? And in fact, you see with these patients with very big left atria, sort of infolding and invagination of that left atrium as it comes off bypass unfilled. And actually, when we filled the patient up, the perfusionist did their bit, and I squeezed a bit of colloid in, the left atrium expanded, and that mass disappeared as the atrium expanded, and those sort of infoldings, which gave the echo appearance of a mass, disappeared. Anyone want to tell me what this is? Spot diagnosis, really. That's our left atrial appendage, but there's a little bit of weirdness going on just above it. For anyone who does congenital work, this is a partial core triatrium. So you can see there's a membrane just arising from just above the left atrial appendage around the pulmonary veins. That was an incidental finding in theatre. Those patients either sort of die usually or require surgery very early, or survive completely unbothered by it. Sean showed us one of these before. This is something else that happens in the left atrium, and left atrial air, as this obviously is. It's something that's taken the surgeons a while to appreciate, I think, with echo, but now they're right onto it, and they try and get rid of this mass, this air. I mean, it's not something they can diathermy or cut out, so they have to syringe it out. But intracardiac air is a bit like a black hole in space. You can't see the air itself. All you can see is the evidence around it, because ultrasound does not penetrate air at all. It's very reflective, and it produces this kind of black hole effect. Final one, right atrial thrombus. You can see the intra-atrial septum there. This is a post-op case rather than a theatre case. You can see the intra-atrial septum there. And this is an attempted 4-chamber view. Again, is that right atrial thrombus? Well, it actually is a right atrial thrombus, but the thrombus actually lies outside the right atrium, and you can see that concavity, and that's a post-operative large clot pushing the right atrial wall in. It's actually completely squashing that right atrium completely down, and having a look around, you could see other evidence that there was bleeding around the heart. Okay, that's me done to time.
Thank you.
I think my 3 take-home messages from this would be, first of all, if you have a myxoma, look very carefully around the septum and do that cardiological trick of going from 0 to 180 around the septum. And also expect complications of the septum and potentially with valves with myxoma. Always take a picture of the left atrial appendage when you're doing your pre-bypass study, or in fact when you're doing any TOE study, because it may subsequently be required 7 days down the line in ICU or another context, and if you can show that there was no thrombus in the left atrial appendage, it is sometimes very useful information. So always take a picture and describe it in your report. And I think the third point I really want to make, which comes from that, is if you're seeing something unusual in the heart, particularly something like a mass, something like that, you're not sure what it is, always go back to previous studies, go back to the outpatient studies that the patient had. They're all available on Medcon now, and describe what you're seeing in association with that.
Okay, thank you.
Thank you very much.
Excellent talk.
So has anyone got any questions?
Thanks for your talk, Nick. Enjoyed that. On the subject of air, do you know of any means by which we can actually quantify the amount of air that is in the heart at the end of a procedure? It's almost a routine, but is a routine thing. We always see it at the end of an open procedure. I have a surgeon looking over our shoulder saying, that looks okay, that will be fine. And I'm saying, well, actually, we've got a sheet of air. They'll poke at it, a few fireflies circulate around the left atrium. Do you know of any means to actually quantify that, to actually give more telling information to the surgeon?
I think people have tried to do that, and it's a really difficult thing to do because of that, because of the relationship with air with ultrasound. You know, it's not like a mass where you can quantify it. I don't think you can. I mean, one of the surgeons says to me, you always find air. And I said, well, that's actually because I look for it. And I think some people don't look for air, but it's very important to do that. I mean, there's 2 kind of types of air, isn't there? You see the small, very echo-dense, small bubbles which collect around the atrial septum, and they're actually very difficult to remove, and the surgeon will do their de-airing and they're still there, and often you just have to come off bypass with those micro bubbles there. But I think that the picture I showed there with the larger bubble of air, I think you can't leave those and come off bypass with those, because that's a very significant collection of air. So the micro bubbles, probably you can come off bypass. With the larger sort of shadow, the larger air bubble, I think you've got to deal with that, and the surgeon's got to get a syringe and a needle and try and go into the left atrium and try and actually suction the air out with a syringe.
Rather than just flicking it with a finger?
Well, I don't think you particularly want to de-air that size of bubble either, really, because potentially that's going to shoot down the coronaries.
I think we've also seen when you have that sort of small speck, not the fireflies, but a sheet of air, and in one axis it appears very narrow, and as you go around your multiplane, actually you see, in particular in the roof of the left atrium, you could see something that's 2 or 3 centimeters wide, and is clearly much more significant.
Yeah, again, and again, you need to look at the left atrial appendage for air, and again, in the ventricle and hiding in the left ventricular flow tract beneath a mitral valve replacement.
Thank you.
Thanks.
Thanks for your talk. I'd just like to talk or ask you about the left atrial appendage thrombus and doing TOEs to all patients if they've been in AF for more than 48 hours. Do you include patients that are 48 hours post-cardiac surgery who've had a TOE at the time, which shows that the left atrial appendage is clear in that group? Would you re-TOE them?
That's kind of precisely the group I'm talking about, really, because I think, particularly after 48 hours of being in AF, I mean, I'm not talking 48 hours post-surgery, I'm talking at the point where they went into AF. And as we know, post-surgery, patients actually start to become quite prothrombotic, actually quite early. So you've got a combination of atrial fibrillation, particularly if it's slow, maybe you've been treating it with amiodarone, a patient who may be becoming prothrombotic. And I think TOE is so readily available to us. I mean, it's not so convenient if the patient's extubated. I agree with that. But actually, it's quite easy to give the patient a little bit of propofol. If you want to cardiovert them electrically anyway, you're going to give them some sedation. So you give them a little bit of propofol. You're in maybe a critical care area. It's very easy to do the TOE. You just slide it in, look at the left atrial appendage, take it out. And that would be, it's not everyone's practice, but that is my practice because I feel very conservative about the risk of any problem from an embolus when it's so easy for us to do the TOE.
I mean, I think one of the problems from the anaesthetic stroke intensive care side is that we're not very good at giving a little bit of sedation and doing TOE. At least I'm not. I mean, they're either anaesthetised or they're not. So
Okay.
it's not just a matter of giving them a little bit of midazolam, for me,
Right.
and slipping a probe in. So it would be, and I couldn't give a GA really in ITU. I'd probably have to take them around to theatres
Okay.
to do it. So it starts to become a bit of a pain.
Okay.
And that's certainly in my institution. We wouldn't routinely do a TOE at that point. I'm not arguing with what you're saying.
I mean, I think I come from maybe a slightly different place because for whatever reason, I've done a lot of sedation for gastroscopes and ERCPs, and I'm used to giving little increments of propofol. So maybe I'm just coming from a slightly different place,
Sure.
and that's the reason why I find I got a low threshold to do it.
And one other quick question. If you get a patient that comes, a cardiology patient, who's been in AF for a week or 2 weeks, they need a TOE. Do you just look at the left atrial appendage and then say, fine, cardiovert? Or do you look at the left atrial appendage and then do a 20-minute, 30-minute examination?
Well, certainly if I'm given the anaesthetic and it's a cardiologist, I don't let them do a 20-minute examination. It's usually the SH, they send the SHO or something, so you can usually bully them.
I think my point really is, you know, if you put the probe down, should you do a full interrogation?
No, I take exactly what you're saying. Because we're encouraged never to do a limited study or a focus study, we're encouraged to do a full study. I think the answer to that probably is to do a full study in 5 minutes. You're not looking for any other specific pathology. You look at the right ventricle, you look at the left ventricle, you look at the valves, you exclude any major pathology without doing all 20 multiplane views. I think, and to a reasonably experienced operator, which if the cardiologist can't do it, then you push them out of the way and you do it yourself, should take 5 minutes, really.
Thank you.
They usually should have had them done if they're a cardiology patient anyway.
Just going back to the AF, mostly...
Only one short comment. I would do it 3D full January in 5 seconds.
Get very good views of the left atrium on 3D.
Just going back to the AF, I mean, it's about 20 to 25% of patients will go into AF post-operatively. And in most cases, it's 24, 48 hours, and they don't need cardioversion. They spontaneously go back into sinus rhythm with either beta blockers, amiodarone, whatever is used locally. But should we, for the very reason you said, should we be anticoagulating these patients rather than doing a TOE on them? Should we not, after 24, 48 hours, put them on?
I mean that's kind of the rationale in a way to do a TOE, so you avoid the anticoagulation. You know they're having their pacing wires taken out at this point, and their drains. There's a whole load of things where you can get late bleeding, following cardiac surgery, and this is the rationale. I mean, there's a very limited amount, really, in the literature about this kind of situation. There's a huge amount of cardiology recommendations about treatment of AF, anticoagulation, but it doesn't really address the post-cardiac surgery population in intensive care. I mean, and my rationale is I'd rather do a TOE, I think, rather than anticoagulate these patients because of the risks of late bleeding and late tamponade and problems following pacing wire removal.
So at what stage do you do the TOE? It won't stop them.
Well, if we were going to cardiovert, if they'd been in it for 48 hours, we were hitting them with amiodarone and they still hadn't cardioverted, or we were going to DC cardiovert them, I'd just do a 5-minute TOE at the time of, I gave them a bit of sedation for that, or just give them a little bit of sedation within an ICU context.
Okay, right. we've got to call a halt here.